Hello, everybody. Good afternoon. I think if you're on the West Coast, it is still morning, the brunch hour. Welcome to this wonderful webinar. Again, I'm Trooper Sanders, CEO of Benefits Data Trust. I have the extraordinary pleasure and honor to work with some amazing people all across the country who get up every day, and we focus on ensuring that people who need help can figure out the help that they're eligible for, that they're able to get that help in as dignified and an efficient way as possible, and that they are able to keep that help for as long as they're eligible. And so that people can meet their food needs, their healthcare needs, education, broadband, heating their homes, all of the things that are part of our critical needs and the wellness and well-being of our lives. And as you all know, so many work on the extraordinary work of ensuring that people have health insurance and are able to access healthcare that improves their lives and saves their lives. And Medicaid is one of the most extraordinary public service innovations in American history. Some maybe of the era and age who can remember life and healthcare before Medicaid and Medicare. And watching old movies where folks were putting money in the coffee can to go to the doctor and stressing out. And of course there are many who still do that we still have to do that, but Medicaid has played an extraordinary role in improving the well-being and reducing the stress of daily life. As we all know, the pandemic put extraordinary demands and needs on our healthcare system and really showed the critical value that Medicaid has to get through the pandemic. And now we are in a situation where millions and millions of people are unnecessarily losing Medicaid, losing access to health insurance and healthcare. And it's an honor for my colleagues and me and Kii and Jamila, who are extraordinary, to be working with public servants and others all across the country to figure out how do we get through this challenge and ensure that people keep the coverage that they need, that we figure out what is the road, if you're part of the millions of people who have fallen off the rolls, how to get you back on, and then going forward, how does the overall system work better for people. I want to thank all of the states, all of the public servants who have been part of this effort for more than a year, working with my colleagues at BDT. I know we've enjoyed visiting many of you in your states. Thank you to our wonderful leader and colleagues from California for being part of the brain trust of this webinar. And on with the show. Kii.
Thank you so much, Trooper. As Trooper mentioned, I am Kii Powell, Senior Policy Director here at Benefits Data Trust. Welcome back to those of you who are joining us for a second time. This is the second of 3 webinars that Benefits Data Trust is committed to doing on the Medicaid churn initiative that we've been working on. We're honored to highlight the great work of the states that we've collaborated with. And I really wanted to highlight why we thought it was important to do a webinar series. One is that we recognize that there is not one solution, one waiver, or one practice change that's going to solve the Medicaid churn problem. In fact, we know that it takes a combination of these many approaches to address Medicaid churn. And second, in our work with over 18 states, we know that one human services or Medicaid system is not the same as the other. In fact, we thought it really important to be able to highlight 3 different states. Again, we started with Rhode Island. Today, we'll hear from California, and then our last one will be with North Dakota, because we recognize that each of these states had different challenges and different solutions that needed to be employed. I'm going to turn it over to Jamila McQueen, who is our policy manager over Medicaid at Benefits Data Trust, and Yingjia Wang, who is the Assistant Deputy Director of Healthcare Benefits and Eligibility at the California Department of Healthcare Services. I will be back at the end to manage the question and answer portion. So look forward to seeing you all again there. And with that, I'll turn it over to Jamila.
Thanks, Kii. Next slide, please. And thank you all again for joining us today. As he said, I'm Jamila McLean. I'm the Senior Healthcare Policy Manager here at Benefits Data Trust, and I've been the lead for the Medicaid Churn Learning Collaborative. If you were with us for the last webinar, thank you and welcome back. But if you're joining us for the first time, we did want to, again, just provide a little bit of context because we understand that there's a diverse audience joining us here today. So we wanted to, again, remind you all how we got here. Now, as you all remember, several years ago, when we all got sent home for 2 weeks, thinking that we would be just sheltering in place for the COVID-19 pandemic, Medicaid, the federal government took very drastic actions to make sure that they could protect Medicaid coverage during the COVID-19 public health emergency. And with that, Medicaid terminations were paused for the duration of the PHE, which led to a significant increase in Medicaid enrollment. However, what that landed us with at the end in April of 2023 is where we saw Medicaid enrollment at the highest level. So as of April 2023, Medicaid enrollment was at 94 million people, and that represented a 32% increase from where we were pre-pandemic. So next slide, please. So we just wanted to present a high-level visual as a reminder of how much has changed over the past 3 years and how we got here. So like I said, it started with COVID-19 being declared a public health emergency and the Families First Coronavirus Response Act being signed into law, which really provided coverage and protection for Medicaid enrollees and some of the most vulnerable people in our nation. So ensuring that they had continuous coverage, continuous access to healthcare for the duration of the public health emergency. And we know that this was not going to be a permanent thing. So states were at the time planning for the end of the continuous coverage requirement, which we learned would take place after the signing of the Consolidated Appropriations Act of 2023, declaring that the continuous coverage protection would end in March 31st, 2023. So all states have been working diligently to ensure that they returned to normal operations in a way that did not disrupt the lives of their Medicaid members as well as their staff. So with that, we saw the first round of Medicaid terminations beginning in April and the end of the COVID-19 public health emergency in May of 2023 this year. Next slide, please. So as Key and Trooper noted in their introductions, BDT is committed to helping states and helping their Medicaid members through this unwinding process. So part of that initiative to help states was developing the Medicaid Churn Learning Collaborative. And we have been really honored to have spent the last 12 months working with 6 states to help them address Medicaid churn during this unwinding period, and to think about how to address Medicaid churn in the long term, thinking about solutions that could go forth past the unwinding. We have been grateful to work with California, Kentucky, North Dakota, Rhode Island, South Carolina, and Washington. And as Key said, and I want to reiterate because I do think it's so important, we're so glad that we had such a diverse group of states. We know that diversity, both in terms of size, location, the physical and demographic makeup of the members was really important to creating this learning collaborative because there's so much innovation that comes with different states having different experiences and sharing it with others. So in working with the Medicaid Churn Learning Collaborative, the states were able to interact with us and with each other in several different ways. Next slide, please. So through their participation, all of our states got individually tailored technical assistance because we recognize that each state is in a different part of addressing Medicaid churn, in a different part of their churn journey. So we wanted to make sure that we met states where they are, and we're providing them with specific solutions to policy and process changes to address Medicaid churn. Additionally, like I said, we recognize the importance of peer interactions. So we held peer calls to make sure that our states got a chance to talk to each other, to bounce ideas off of each other, to share their innovations, because this is a unique time when all of our states are going through the exact same problem, and we did not want to recreate the wheel. And we know that the best innovations come from the individuals that are working on this problem, on addressing this solution. As Trooper said in the intro, we also conducted site visits. We were fortunate enough to spend a day working with each state, figuring out solutions to their policy and process challenges, and identifying ways in which they can innovate during this unwinding period and beyond. We held webinars with subject matter experts and worked to connect them with tools and resources from other subject matter experts throughout the nation. And finally, we had a kickoff convening to bring all of the states together, and we'll be doing a closing convening at the end of this project to again bring the states together to reflect on the changes that have happened since the beginning of their work with us and through now, as we are now several months into the unwinding period. And with that, now that we all know how we got here, I do want to say and introduce again Yingzhe Huang, who is the lead for California and has been such an instrumental part of the Medicaid Churn Learning Collaborative. She has been responsible for co-leading all of the work that California has done in terms of adopting all of the policy and process options. And on the fun side, Yingzhe is originally from Honolulu, grew up in Honolulu, and loves to travel internationally and always loves providing folks with tips for visiting Hawaii. So Yingzhe, thank you so much for joining us today. And to kick us off, why don't you tell us a little bit about the Medicaid landscape in California?
Thank you, Jamila, for the warm welcome. I'm Yingzhe. So California Medicaid, Department of Healthcare Services is just a bureaucratic name for the Medicaid agency in the state of California. And we call it Medi-Cal, the Cal part. California currently has over 15.5 million individuals that we cover, close to 40% of California. And from a national perspective, we are the largest Medicaid coverage program in the nation. About 15% of Medicaid lives lives in the state of California. So the unwinding journey from a landscape perspective is pretty enormous. And we do have 58 counties in California. We are a county-administered state, meaning that under the state authority, our counties at the local offices do the actual Medicaid eligibility determinations. So there's another layer of operational detail and considerations when we're implementing such massive changes. So the unwinding landscape is pretty turbulent, and I think we're now in month 4, and changes continues to come and more, and happy to kind of share our experience with everybody on this call today.
Great, thank you. Could we move to the next slide, please?
So here in the slide is just a really quick overview of the consumer journey for the member. And if you could keep clicking through the slide, so the graphic, we have a little graphic that we show folks. What does the continuous coverage unwinding really mean? So in March of 2023, as Jamila was sharing, the unwinding basically began on April 1st. And California chose to begin our unwinding journey in June because we technically, under the federal options, had 14 months to really unwind. California being this size and this rigor of this massive change, probably the biggest since the Affordable Care Act. When I was also here in 2013 when we implemented this in the state of California, very massive. So it's really another turn of the landscape in terms of where we are. 3 years, no redeterminations, which is such a critical piece in the Medicaid structure. We took all the time we needed. So, and this kind of a visual here shows from an average member of the Medicaid program in the state of California what to expect. So we really used the first 2 months to really start the first part of the redeterminations journey. And this is the ex parte, and kind of later in the presentation, I'll share from a data perspective why that is so important for us. And in California, we pre-populate all our redetermination forms. And it's not just a one piece of paper, it's actually over 19 pages of documentation. So you can imagine from a federal perspective why the redeterminations is such a huge kind of burden, not only on the states, but also on the consumer end as they're kind of filling this out, because they haven't done it in 3 years and the forms are massive, and the amount of information that's being shared with the member is also very, there's quite a bit. So from that perspective, we think of the unwinding kind of every cohort in the next 12 months of the unwinding at every 3 months. So here the unwinding renewal is always 3 months, April through June. And of course, in May, we will be doing redeterminations for individuals with a July due month, for example. One of the biggest principles of California in terms of how we're thinking through this unwinding, our goal is to maximize the continuity of coverage for our members. Initially, we thought through and anticipated that and forecasted about 2 to 3 million individuals of the over about 15.5 million individuals at that point in time will lose coverage as a result of the unwinding. And it's important to remember that kind of in this context, we were covering individuals that may not need the Medicaid coverage because we were not able to disenroll them under the continuous coverage requirements. So that's kind of the goal that we have from an umbrella perspective as we were going through kind of the policy implementation. And also just from an operational perspective, kind of knowing that we will lose people along the way. And from a data perspective, how we're going to represent that. Next slide, please. So here, the next couple slides just kind of showcases the various federal flexibilities. From a CMS perspective, from a federal perspective, they have not used an E14 since the Affordable Care Act. I remember there was a plethora of them during 2013 when states were starting the implementation of healthcare reform. And now the E14s have made their way back into the horizon because the unwinding is so massive in size and complex. So California really leveraged many of the federal flexibilities. CMS calls it the 1902 E14As, which is an authority for them to offer states a very temporary flexibility to really waive certain stringent requirements under the Medicaid provisions. California have elected over 17 of them in various ways and form. We have eliminated the verification of assets for non-magi, for example, for the short term, because in the long term, California will be eliminating assets on January 1st of 2024. So meaning that as we were starting the unwinding mid-year in 2013, we have a really weird lame duck period where we may be penalizing people who have assets over a certain limit, for example. So we needed kind of a continuing or a bridging policy. So we were able to leverage an E14 to basically bridge us until we get to that full elimination on Jan 1 of 2024. Likewise, we received quite a few flexibilities here on this chart, just elevating a few to help the homeless populations. We know the pandemic has really changed kind of the course and the landscape of the people we cover today. And it's very important for us to figure out ways to kind of bridge and maintain coverage for the most vulnerable. So here, the zero income or individuals with income at or below 100%, whereby using these federal flexibilities, we have an ability to ex parte them, basically advancing their renewal and continuing their current coverage for another year. So the next couple of slides kind of showcases the various plethora of federal flexibilities we were able to implement, and the corresponding we have implemented actual letters in the state of California for our 58 counties to implement. So this is a very good example of a county-administered program where we at the state level have the authority to obtain and of course execute certain policies, but the counties are the ones who will take our instructional letters and actually implement it at the ground. So there are some business process pieces that the state will provide full flexibilities for our counties, but we will provide the actual policies for them. And that's why we have some letters here if you're interested in taking a look at how that looks like. Thank you. Next slide, please.
Thanks, Deja. And before we dive into the data collection piece, I want thank you for sharing sort of the magnitude of the California Medicaid program and the amount of lives that you all cover, and also really elevating for us and reminding us how big this unwinding is, you know, in comparison, right? As you mentioned, the largest sort of change in the Medicaid program previously was the Affordable Care Act. So this is a huge shift, not only for members, but also for the agency in adopting all of these options. And you talked a lot about sort of the vast magnitude of the flexibilities and waivers that you all set up. And I know we're going to dive into the data. So can you talk about why it was so important for you all to enhance how you collected the data and how you represented the data and made it available? Why was that important for you all with helping in the Medicaid unwinding?
The data was one of the most critical kind of priority items for the state, primarily because we had little visibility into the various demographics that we cover today. I think the pandemic changed a lot in terms of how we look at things. Our members have moved throughout the state to different zip codes, for example. We had no visibility into the calendar year of 2023. What does Medi-Cal really look like, and who do we really cover? So we actually piloted. So what we're going to show in a little bit is an interactive dashboard where we actually break out by certain groups of eligibility measures, where we're actually slicing and dicing and looking at our demographic by written language, ethnicity, and gender and age. We have never done that before. And by that, it is also a way for us as the months go by, because we refresh this monthly collection every month by the unwinding month. We have an ability to really pivot and troubleshoot. For example, why are certain populations so prone for disenrollment, for example? We are going to deep dive in with our partnerships on the ground, like the navigators, and really push for more engagement at the ground in Alameda County, for example. So the data collection offers us a perspective where we could actually pick up and learn best practices and also kind of pivot our strategy, because we know that with the unwinding, the policies at the federal level will morph. Likewise, at the county level, operational practices will need to be adjusted. And the data will be telling us in terms of every month, do we need to change our messaging to the public? And do we need to pivot certain business flows to really adjust to what the reality is for today? For open enrollment, for example, that's coming up in October, we know we will hit our highest volumes for redeterminations. Do we need to adjust our strategy after we see the October data? So
thank you. I think that's a great segue into the data dashboard that you were talking about.
Great. So the data dashboard, we're going to actually show you a glimpse of it. And this unwinding dashboard is posted on the California Medicaid page publicly for folks. It's interactive, and you have an ability to see. So this is just one of the slides of the 15. It's interactive. You have an ability to kind of click through all the 58 counties. This is the statewide view. So if you click on Alameda, for example, at the top, you will see the different kind of demographic slices being, changed in the pie charts respectively. So it's refresh every month, meaning this is the cohort in the month of July. And what's important about this is our external stakeholders, consumer advocates, or members of the legislature, if they were to look at the areas they are interested in, they can concentrate and help us concentrate outreach, for example, in certain areas of the state. And likewise, as I was sharing, our strategies may change and morph depending on what we see. And from a transparency perspective, this dashboard also includes application measures and total enrollment, which is also important because Medicaid agencies are open 365 days a year. We're never closed for business, meaning that applications continue to roll in every single day. On average, each month, the state of California receives over 150,000 applications of individuals coming in through our doors. At the same time, what's being adjudicated is also redeterminations. We talk about redeterminations quite a bit through the unwinding, but a critical feature of this unwinding is also juggling the same type of workload for applications. So we do provide a snapshot of what that looks like in this dashboard with these interactive features. So you have an ability to kind of click through and kind of look at who's coming in our doors today, by month, and also at the same time from a redeterminations perspective by county, slice and dice through various demographics. So if you could kind of go to the next one, I think slide 15. We also have an ability to look at by month for disenrollments, because as you know, at the federal level, there's significant interest from CMS on procedural terminations, which is individuals who did not return their packets and are thereby disenrolled from the Medicaid program. So we have an ability to look at, break down the various reasons by month for disenrollments, also slice and dice by county. So you can kind of see by county what it looks like. Large county, a smaller county where there's probably more inclination for certain things happening at the demographic. So every month we have an ability to break this out, and it's just another way for us to keep informed of a strategy, whether we need to really push on the 90-day cure period, which is the piece that now we are actually shifting our messaging to focusing on the 90-day cure, just as an example, because we're seeing large procedural termination. People who are procedurally term have an ability after they're disenrolled to come back into the 90-day cure. In California, call it a cure. At the national level, I think they call it the reconsideration period. You have 90 days to come back into the program, be reinstated in coverage. So we want to make sure these folks who are procedurally termed understand that they still have a chance to come back in. So we're using this data and shifting our messaging from an outreach perspective to really highlight and elevate that for the general public, so that not only they know this is happening, but they do have an opportunity. And this dashboard will update after the 90-day mark. It will update and the numbers will refresh. I think in summary, what was the most important takeaway for the state is that we were not anticipating we were anticipating some less than normal trends and percentages post-COVID, from a disenrollment perspective, from a retention perspective. But as June and July have demonstrated from an outcomes perspective from the data, our post-COVID, our unwinding percentages are actually very similar to our pre-COVID trends. So I think that's an important takeaway. And I think we're still learning as the months go by. We're only now in September, so we're hitting month 4 of the unwinding, so more to come. But this time, I think we have come out, at least the first 2 months of the unwinding, in a very good position, very kind of proud of the work that we have done. I think we could go back to the presentation. Thank you so much.
Yes. Thanks, Inja, and thank you for sharing that. Again, want to underscore that this is a publicly available dashboard, so folks can go and play around with the data. Is there anything that you want to highlight in terms of what folks should keep in mind as they're using the dashboard or as they're navigating this tool? Because it's as you mentioned, you all are piloting it for the first time.
And I think maybe an important kind of note to keep in mind as folks are looking at this is this represents a snapshot of the Medicaid program at the point in time of the data query. And the reasoning is, as we know, as I shared, Medi-Cal is open 365 days. Every day there's just movement of eligibility statuses. So I would urge folks to kind of look at it as a tool to inform you of kind of what the picture of what the landscape of California looks like. But definitely there should be no conclusions drawn as things shift every single day. And we are positioning this as more of a tool to help the department and also external stakeholders, as well as members of our legislature, be informed of kind of the progression of events from an unwinding perspective. And we also have an ability, I think, in there for folks who are interested to download the raw data from the dashboard. If you love Excel spreadsheets, to kind of take a look at it by 58 counties across 72 data sets, that's also available for you as well. The first time we've been able to do this. And we've seen members of the public actually take this and actually look at their counties respectively, and then have come back to the department with great feedback and suggestions.
That is awesome. Thank you. And it's great to see the data be available so nimbly. And as you mentioned, things are constantly changing in the Medicaid program, as it is open 365, and you all have regular operations that have continued to go on. So to be able to provide this data so quickly as things continue to change is excellent. And I think that this is actually a great time for us to segue, as you mentioned, into the county administered part of California. I think one of the unique things about California is, as a state, in addition to just the size of the program, is the fact that you all are county administered, which does provide its own unique challenges and benefits. So why don't we talk about how that how the unwinding has looked from the perspective of a county administered state.
So this construct really does kind of complicate these massive implementations. So with California, the state, we're responsible as the single state agency under federal authority in terms of the oversight and administration of Medicaid. But the day-to-day operations of the program is handled by our 50 counties. Each county has a local offices. Like the county of Los Angeles has over 4 million individuals. They have like 90 district offices. And each district office, there's a district manager. So if you could kind of tell from that kind of level of operations that it complicates in terms of implementing a policy. And with something as huge as the unwinding, we have to do some very seamless communications throughout the state. So for counties, it's very important. We've learned quite a bit from the implementation of the Affordable Care Act that the state needs to have a single state voice. So we've created a single location, first and foremost, for all our counties. So they all know that we're speaking from one voice, one policy for all 58 counties, a resource hub for them for all policies, letters, as well as state recorded trainings. We actually weren't able to do that, but now with the technology now in 2023, we recorded actual trainings at the state level. We used to have an ability to go and travel and do trainings across the state, but with the state of the pandemic, that was impossible. But we were able to film it, put it on YouTube, put it on an SFTP, for example. All counties are provisioned now through this technology to kind of embrace it and have an ability to download and even use it in what they call county eligibility worker training across the state. Counties have been creative and have leveraged those best practices, created focused specialized task force within their counties who have actually had experience with the Affordable Care Act and the rigor of it in terms of using these very seasoned leads to lead the redeterminations work. The state we at the state level collaborate with the counties pretty regularly. We have bi-weekly webinars similar to how CMS have webinars for all states. We have an all county call every week at the same time where we elevate emerging issues and we elevate and pick kind of like a naughty policy area where we kind of go through from a policy perspective how things should be operationalizing. And it offers a very quick on the feet kind of pivoting of focus for the counties so they understand what the state priorities are. Secondarily, it offers them a very good forum for them to ask questions through like a WebEx mechanism, for example. And so we also take good Q&A, meaning that we take these questions that we receive from counties, because probably many counties probably have a similar question on like a transitional Medicaid case, for example, which is a consumer protection program, very complicated in terms of the rules and how it interacts with the unwinding policies. We will take a lot of these frequently asked questions, develop actual Q&As where we do publish it in a policy letter for counties, so they can always evoke and use that in their case notes. In this policy instruction letter, the state is instructing us to use XYZ flexibility for that. So it offers a level of consistency, a main kind of central repository for everybody to go to, and also leveraging kind of a dedicated workforce. But I think those things are just kind of critical collaborative kind of pieces. But one thing I do want to share, I think probably not new to many of you, is all our 58 counties, just like the national kind of workforce, is experiencing a shortage in labor. And so we recognize that. So we focus very heavily in terms of how we could help them with the staffing. Next slide, please. We, in the state budget, have allocated additional dollars, $142 million for all our counties across the state for the work. Also, understanding that they probably have shortages in those critical features of the business process, like call centers, staffing lobbies. We have requested and mandated them to provide what we call county readiness plans to us early before the unwinding actually commenced. So in February of this year, each county was to go through a state checklist. We took the CMS version of it, adapted a checklist for California's use. Counties were to sign and tell us and test to their readiness for the unwinding. And within the readiness kind of checklist, it had all these areas on the PowerPoint on the previous slide where they were to tell the state, are they ready? And they check off the boxes. And if they do not check off the box, they would need to tell us whether there is a technical assistance required for that area. And we actually had technical assistance calls with every county just to address very specific issues, just so that we know we're prepared from a mentality perspective and also from an operational perspective, how to help them as April 1st came. And I think this has been one of the most helpful instruments that we have been able to use just to help them navigate such a windy road for the unwinding.
Thanks, Inja. And I think what you just explained here and everything on the slide just sort of underscores the added layer of complexity when it comes to navigating as a county administered state. I'm curious, from a data perspective, what is the data telling you about going through the unwinding as a county administered state? Are there any specific challenges or things that you want to elevate?
So kind of overlaying on top of kind of the county construct of 58 counties, we are going through a migration of the eligibility systems. At one point in time, California had 5 eligibility systems. And now we are in the process of moving 2 county systems into one, because prior to COVID, they already moved to like 2. And also we have a state system where we interact with the Federal Services Data Hub for the purposes of MAGI verifications. So from a data perspective, we actually have to collect the information from 2 separate systems, the county systems, and kind of understand QC the information into one. And we do see, depending on which system you are in, we have now 55 counties have already migrated to what we call CalSAWs. And at the end of December, we will have migrated the full 58 counties into one system. We see some variances depending on how the systems were built and how the functionality was implemented that may have changed how the data looks like. So as we are going through the unwinding with the migration and kind of all the the system freezing of the code, et cetera, where we just have to kind of manage around this very messy cohort of policy and system changes. The policy pieces, the data pieces, we will actually have to reconcile based on that backdrop of understanding that there is going to be data anomalies as the systems are merging into one. So this kind of adds obviously to the complexity of the data reporting that you just saw in the unwinding dashboard. But I think overall, the complexity is there, but I think now we have gained enough experience as the state whereas I probably can't say that 6 months ago, to understand why certain counties may report their ex parte a certain way. They may report their termination numbers a certain way. And now we could speak pretty eloquently to it because we have gained that level of understanding and experience kind of throughout the last 6 months with both the migration and the kind of the data quality reconciliation.
Thank you. And I think that again underscores how very exciting it is that you all are able to share such updated data on what's happening with your members, working with multiple systems, reconciling the differences, understanding what they mean and addressing them. That is no small feat. So I think it's amazing the amount of work that you all have been able to do with your navigating those data challenges within a year, within a very short time, and being able to have this publicly available. So huge congratulations there. And I think this is actually a good time to shift to another very complicated topic, which is consumer outreach. As you mentioned, California has 15 million Medicaid members, and it was really important to let everyone know that this is happening. And I think we all are aware that Medicaid is not a program that advertises. It's not, public benefits. The public benefits fair is not a program that does these large scale campaigns as we are seeing with the unwinding. And I know that California has been a huge leader in developing ways to reach members, both through the state and through other stakeholders. So I want to kick it to you to talk to us about your outreach efforts, how you all approach the unwinding, and how you utilize consumers to inform your outreach.
Oh, yes, the consumer outreach part has been another pillar of the unwinding process. We actually started thinking about the outreach when we first, in 2021, actually sent out a massive mailer to all our 15. At that time, it was actually 15.8 million individuals. And we received almost 2 million return pieces of mail into our office. And what that tells us is we have a huge percentage of our members that probably have moved. And why that's significant is if we have loss of contact for Medicaid, what happens is you will be disenrolled for that very reason, because you're not able to actually submit a redetermination packet to the county for re-verification. So we started kind of conceptualizing a program, and we call it the Coverage Ambassador. So we've launched this last year in April, where we have recruited individuals across the state, whether you are a community-based organization, a state agency, a county agency, consumer advocates, as well as managed care plans, because we are a managed care state. To sign up, because these coverage ambassadors are what we call the trusted messengers of the community. Whereas when government sends you a letter, you sometimes may not want to open it or may not understand it. But when you have a community messenger, a trusted messenger from your community knocking on your door, and you're actually able to help them, or if a local organization down the street is able to give you information with their logo, you're more than likely and more willing to open and try to understand what's in it. So we knew we had to do that and actually recruit individuals to help us with the unwinding, because our goal was, number one, to maximize the continuity of coverage. And by that, we need to make sure we have correct addresses. So our coverage ambassadors, the first assignment we gave them was to make sure that they are outreaching to folks, asking them to update their contact information with the local county offices. And we started off with only 150 people the first day. And then now in September of 2023, we have 4,000 entities across the state of California signed up with us. We have developed a resource page for our coverage ambassadors. And later in the presentation, sharing a link with you about the resource hub, where we actually have created in all threshold languages. So in California, 19 threshold languages. We have translated snippets, frequently asked questions, flyers, where our trusted messengers could personalize the information and share it with the individuals in the community. Please. Here it is. And here's our community, Keep Your Community Covered Resources hub. As you can see, we have developed, using these cool technology, QR codes, for example. We've never done this before in Medi-Cal. First time we're launching this, and you could tell from my Zoom background that we have even embraced it to the Zoom environment by having backgrounds with the logo and with the Medi-Cal logo. And we use these colors because this is the color of the card for our beneficiaries. So they recognize the Medi-Cal logo. And we actually have done consumer testing, meaning that as before we even began like kind of designing the logos, the family with the umbrella and the child, we actually went out and actually talked to over 25 groups of different members of our individuals that are enrolled in the Medi-Cal program and shared samples of things that resonated with them. Shared the Keep Your Community Covered was actually chosen by them because they knew that that actually resonated with them. It didn't sound too direct, didn't sound threatening, but it also gave a very kind of nice, warm undertone in terms of what they needed to do in terms of action. So we tested a lot of those messaging, and a lot of this messaging is now in this resource hub right now in this slide, where you can actually click through it and download this. And this is open for the public. You don't actually have to be signed up to be a coverage ambassador to open this public website. You could download this for these resources and actually help us kind of spread the word. And we update it pretty frequently. And we even now have videos where we have purchased media buys using a vendor in, basketball games at that point, early in the year. And also kind of across television, radio, ethnic media, also being a strong push at Univision, Telemundo, we have, and also across a lot of the ethnic media outlets from the print perspective, pushing this message of keep your community covered, update your contact information, look out for your redeterminations packet. And we also tested one important feature throughout a lot of our materials. You'll see a little figure holding a yellow envelope. We have purchased all the yellow envelopes in the nation and used it for our redetermination packets. So our members know if something comes to you and you open your mailbox, there's a yellow packet, it's probably your redetermination packet. Previously, we sent it out in white normal envelopes. But because of the unwinding, we actually thought, okay, we need something more recognizable, people understand, needs to be an important feature in the outreach. So we have developed and, picked that to be the key, if you will, kind of in our outreach. Next slide, please. Here's another kind of example of general messaging toolkit. And we actually give in each threshold language, there is always a kind of a background piece for our coverage ambassadors to look at kind of what the goals are and kind of what kind of messaging, if somebody does approach a messenger or an ambassador on how can I do X, Y, and Z, we actually have a response prepared for you to share back with the member or anybody that's inquiring. So it really does, we really try to think of all angles of the communication. So you don't actually have to go and try to Google or Bing or try to find answers and piece it together yourself. If everything is in one toolkit for you to use and it's all in the resource hub. Next slide, please. And here's an example of all the social media graphics, which we did test. And you'll see here, you see the yellow envelope in all the figures. And it is something we designed just to make sure our members know. Again, if you see a yellow envelope, this is it. And we actually also sent these videos along with the graphics to doctors' offices. We know we spend a lot of time waiting in providers' offices. If you're sitting waiting for your PCP, you'll have these videos that will keep looping in the doctor's offices so folks understand like, okay, this is happening. This event is happening. I need to pay attention. Not everyone will get their yellow envelopes at the same time. So if you don't know your renewal month, you should check on your online account. If mine's is coming up in December, just know it's probably coming up soon. I should pay attention to it. Once I get it, I should review it, sign it, turn it back in. Next slide, please. Another example of print. We also printed customizable flyers for everybody who's interested, and we shipped it to them so folks could put it in their offices or hand it out to anybody that is interested. And here are some of the things too, if you're interested in taking a look. Thank you.
Thanks, Yingja, and thank you for sharing those examples. I think that you all taking such a proactive approach to developing these materials help to ensure a level of consistency. You talk about sort of the differences in the county offices, and it was so important to have that one message across the entire state. So creating it and having that out there. I'll also quickly say, I think Anthony said that he had trouble ordering envelopes on the last webinar, so I'll let him know that you all bought all the yellow envelopes, and that's where that will end. So with that, I'm sorry, good.
It caused a shortage, that's for sure. Yes.
The California caused the yellow envelope shortage. Maybe each state should be assigned a specific color, so that would avoid the yellow shortage. So with that, I'm going to kick it back to Key, who's going to lead us through the Q&A portion.
Thank you so much. Yeah, Jamila, I noted that as well. I was like, what color did Anthony say last time that they were looking for? But that's an interesting strategy, right? And it tells us, right, states are trying to use really creative strategies to really, like, you know, on neon lights, like draw your attention to this envelope, pick it up, open it, you know, and I think that makes a lot of sense.
Okay, you've accidentally muted yourself.
I did accidentally mute myself. Thank you so much. As a reminder, if you have questions, please feel free to go ahead and put those in the chat. And I will be facilitating this Q&A portion. I'm gonna, okay, well, just a bunch are jumping in. So I'm gonna go ahead and kick us off. One question that we have, Yingxia, is, will California be asking CMS to consider making any of the E14 waivers permanent?
Oh, that's a great question. We are advocating for that. I think many states are. We've never had such a plethora of flexibilities, and now this is kind of like a test trial to see how many that we're able to utilize and net value from, and we're already seeing a lot of value. So we will be.
That's great. I think that's wonderful. I would love to be, I'm really interested, like, which ones, because as you mentioned, I think you guys are 17. I mean, that was just like eye-opening. Another question in the chat is, what was the experience of working with other states in the collaborative?
It's been very fruitful. I think it's so interesting to hear how other states are navigating kind of their state landscape. I think we mutually put our heads together to share about, you know, how to put together talking points once our data is released. We anticipate lots of different voices and responses. And I think we were able to kind of collaborate and talk through like what to expect. So it was very interesting to hear, like, you're not alone in many of the issues. It's good to have a friend when you're navigating a very aggressive and rigorous kind of journey.
Absolutely. I always say, like, who are my smart friends that I can call upon, right, in these moments to figure out, like, what else could I be doing? So I think it's wonderful that your cohort of states were able to draw upon each other's experiences as well as challenges. Sometimes we learn the most, frankly, from a challenge. Speaking of, the next question in the chat is, what are the biggest challenges right now in terms of implementation, both from state and county perspective?
Yeah, I think the biggest challenge is California is bracing for some of the largest eligibility expansions in history. Jan 1, 2024, we will be expanding to the last age segment for undocumented individuals, 26 through 49. We're anticipating 700,000 individuals, and that adds on to kind of the current volume that we have, and also the asset elimination that is coming up Jan 1 of 2020. And kind of navigating kind of the policy convergence of those two big policy pieces, kind of on top of the unwinding, on top of the system migration, and the stabilization of that is probably going to be the most challenging, and how to make sure we're kind of maintaining the momentum of our counties. It gets tiring. I mean, they have limited workforce. Most of them have huge 20 to 40% vacancies across their county offices, and managing that will be difficult.
Yeah, that sounds like an enormous feat. It did prompt another question, which is that you mentioned that you are starting in January, we'll have permanent asset elimination for non-Magi populations, I believe. What was the motivation for that? Was it that you all decided as a state to finally take up a option or waiver that was available to you? Was it enacted through legislation? So maybe a little bit more on that.
It was enacted through state legislation in 2020. We actually took it by 2 phases, and I think it kind of collided with some of the things during the unwinding. So, and I think people are actually, more states are actually entertaining, trying to push and advocate for this through their state legislature, because I think it just makes everything much more administratively efficient. And secondarily, just kind of looking at the program from modern eyes in 2023, it does make a lot of sense.
Yeah, thank you for that. That's very helpful. We have a couple more questions in the chat, so I'm going to combine two of them. One is asking about what is the data telling you, like what's the story showing, and another is asking kind of the same question, which is what are the reasons for disenrollment? Is it address changes? Is it homelessness? Is it something else? So, you know, what threads are you learning through your data?
So from a data perspective, I think we are learning that we have a large group of adults, more than children actually, that are being disenrolled. And we're kind of looking into that and using our health enrollment navigators to actually do targeted calls to these individuals and doing surveys, for example, to kind of check in, see, why are you not returning the packet? Secondarily, the top disenrollment reasons, the top reason for, you know, being ineligible for Medicaid is because they did not return their packet. And we are finding that through the same kind of navigator targeted outreach, many of these people probably have moved, never reported that to the state. And secondly, most of them reported they don't need the coverage anymore. So it really hits the two kind of assumptions we had going in. And that's kind of what the data is telling us preliminarily.
One question about that, when we're looking at that, when we went to your data chart, I think it was slide 15 out of 15, and you had procedural reasons versus voluntary, right? Could voluntary kind of be hidden in procedural reasons, in that somebody just decided it's not worth it to even send anything back to California? Like, I know I don't need it anymore and I'm not going to do any work.
Yes, absolutely. We definitely think there is a group that probably has coverage now for, like, they probably gained employer-sponsored insurance. They don't need it. They're like, well, I'm not responding to this. So absolutely.
Okay. That's just an important thing for us to note about the data. Like always, data is always imperfect in some way, shape, or form. And so just an important note. And we have 2 minutes left. I'm going to take one last question to eke every little thing out of you that we can. But with the staffing shortages, are you relying more on managed care health plans to make outreach to current Medicaid members?
We are. Many of our smaller counties are using our MCPs for that.
That's great. Well, I want to thank you so much for your time today, Yingja. That was just a lot of information. So the amount of energy and like thought that California has put into this, it's just incredible. And I'm still, the magnitude with what you all have to deal with, still, like, my eyes get so big when I think about my own state administration experiences, and like my whole state is a third of your Medicaid population. So, you know, it blows my mind away, sincerely. So what an incredible job that you all have been doing. And I also just wanted to reiterate a great thanks to Jamila for all of her great leadership on the Medicaid Churn Learning Collaborative. And finally, to Robert Wood Johnson Foundation, who funded all of this work. We could not have done this without them. So we are incredibly grateful for their support. It's 1 o'clock. So thank you so much, everybody, and have a great day.